So you should be able to see the slide on the screen right now. So the framework for this, let me go back there. The framework for this really has to do with the growing understanding of the importance of non-pharmacological care, and seeing things like movement and pain education actually as actual treatment interventions rather than just things that we get people to do. And interesting research recently talking about how some non-pharmacological interventions actually have equal pain relief in the long term compared to using opioids. That's sort of good news for us. We just need to figure out how to use these non-pharmacological interventions. And of course, in terms of movement and, well, specifically around movement, we know that the best outcomes really do come when we are able to find a way to move with more ease. And so that's sort of the overall framework of this. So we'll have to go into the nitty-gritty as we, or the details as we go here. So just a quick point that I do have conflict of interest. I'm a physical therapist and I'm not paid for by the public healthcare system. So I do have my own business and I create resources, but I'm going to mitigate all that by making sure that I tell you about what's research evidence-based, and then what things are theories and what things are ideas, and so we can frame them all in a good way and understand that. So our objectives here really are to talk about education as a therapeutic and evidence-based therapeutic intervention. And I think if we move away from the research and think that knowledge acquisition is a really, really important thing when pain persists. I'll explain to you more as we go along here about this, but to ignore knowledge acquisition as a treatment intervention really is to ignore the lived experience of pain and the barriers that arise when pain persists. And so then the second thing is, so there's that knowledge, but then the second thing would be how do we apply some of these ideas of providing pain education through movement. And that may seem very odd to think of at the beginning, because a lot of people with pain will say, well, it hurts to move. So why would you be using something that hurts as a treatment intervention? So I'll explain to you more about what we mean around that as we go here. So I thought it would help to talk about a case study to start with, just to give us a bit of a reference, and we can talk about this case as we go along. So Fran is 45 years old. She injured her rotator cuff muscles, so the muscles inside her shoulder. About 9 months ago, she's a care aide. She was helping move somebody from a bed to a chair, and there was a bit of a slip. And when she caught the person, so she stopped the person from falling to the floor, but she felt this pain and injury in her shoulder. The pain didn't resolve quickly. They ended up doing MRI, and it confirmed that she actually torn an aspect of a rotator cuff muscle, enough so that they sent her to a surgeon, and the surgeon said, this is not one of these things that we can effectively fix, but also validated for her the fact that it hurts. There's a real thing in there, and that's why it hurts. So she's tried physical rehab. It hasn't changed her pain or her function very much, and she says, she's tried to push through the pain, and she's tried to avoid the pain, avoid making the pain worse when she's trying to move and do the physical rehab things, and really nothing works. She says that she can distract herself from the pain and that she has some control over the pain with use of medications, but other than that, she has really no pain control. And when we talk to her about her pain, she says that she figures that these sort of things happen when we get older, and she really doesn't have any expectation that she'll be able to get better because the tissue's there. They've said they can't fix it. And if they can't fix it, then obviously the pain and the limitation will be there. This is sort of where she's starting. And as a healthcare professional, we'd be thinking that there are things we would want to educate her about. So if we think about her beliefs in terms of pain and disability, I think that's an important thing to recognize, is that Fran, like a lot of us, have beliefs about pain, but we also have beliefs and attitudes towards recovery. And I'm sure you see some of that from what the simple description we've given so far. But one of the things that she believes is that if there's no way to fix the tissue, then there's no way to create a lasting change in the pain or function, which explains why she's using distraction techniques. Right? She's not using techniques that would intend to change it down the road, just to so she can do things, so take her mind off it. And of course, this means that in terms of the pain, she has a very much an external locus of control, which means that she believes that she really can't influence this, which is pretty much the same as saying that she has low self-efficacy, a belief that she can't really influence this at all. Related to this particular issue, Fran, as a person, actually has a fairly strong internal locus of control. She believes that she can change a lot of things in her life, and she's pretty confident at her capacity, but she doesn't see any capacity of being able to change these things. Fran also sees that her belief is that pain is immutable. And this is a very common belief about pain, is that when pain is persisting and is there, you get the sense that it's not changeable. Just the fact that it's been there this long period of time, and when you try to change it with movement and other things, if it hasn't changed, often we get this idea that it is immutable. She also has an idea that her function couldn't improve if the injury is not fixed. And she has this idea that when she moves, when the pain increases, that she's damaging herself more, which makes a lot of logical sense. That's the way that pain often works. But when the pain persists, we know that this sort of connection becomes problematic. So each of these beliefs would, you can imagine if you believed, as Fran believes, that pain means damage, and that if you can't fix the tissue, you can't change the pain. And the pain itself is not something that I have any control of. Hopefully you can imagine that her approach to getting better would be different if she had different beliefs. And so part of what we want to try to do when we're working with people in pain is to identify some of these beliefs, but then think of how could we provide the person with education that would teach them that this isn't exactly the way it works. And so we need to talk a little bit about how we use verbal and written pain education, but then talk about the movement piece, how we could actually do this. And I'm sure right now it's a little bit hard to imagine how you could use movement for this, but we'll get to that. So what knowledge might help? Well, it would help to give her an idea that pain's not an accurate indication of tissue health. We know that the amount of pain that a person has and the amount of tissue damage they have don't always match up. And when chronic pain or when pain persists, it certainly this match seems to be a lot looser. So we need to get her that understanding that pain isn't a tissue health meter. And as I say that, I want to make sure that those of you hearing this are if you listen to other people within the world of pain management, you will hear a lot of language that I use that's very similar to other people, and especially Lorimer Moseley and David Butler. And that's one of Lorimer's, that's the first place I heard someone saying that pain's not a tissue health meter. And I think that's a good way to think of it. So we need to find a way to teach her that. We also need to teach her that if pain's not an accurate indication of what's happening in the body, then we really shouldn't be using it as a guide for how to get better. And this becomes important both for the person in pain, but for even healthcare professionals, because often we tell people to use the sort of extremes of this. Either we say, use pain as the guide, which doesn't really work most of the times, or sometimes we go the other side and tell people, pain's not accurate, so don't listen to it at all, which can be really, really hard for the person in pain to understand what to do with that kind of information. So we'd also want to tell her that all pain has to do with what's going on with the body and what's happening within the systems of the body, especially the nervous systems. And so if all pain has to do with what's happening in what's happened in the body, but also how the systems are dealing with it, we'd actually want to address treatments to the way the systems are dealing with things. And in this case, we can talk about the nervous systems. Although it's not just the nervous systems we would want to talk about, that's a great place to start. Because we have some evidence that says that people can learn this and it makes some sense, and then you can expand the person's view of realizing pain has to do with the hormone system, the immune system, many other systems of the body. And so this word here, neuroplasticity, is that if pain has to do with the nervous system and the nervous system is changeable, which is really what the neuroplasticity means, then we should be able to make some change to this. Actually, one point, if you've not heard that word before, neuroplasticity, think of it versus neuroelasticity. So there are aspects of the nervous system that you can change really quickly, but then sort of you let go and they go back to where they were before. There are other aspects of the nervous system that can take a lot of time and a lot of effort and a lot of repetition to change, And then once those are there, they typically take time to change them back. So like plastic, which can be molded into any shape, it just takes time and effort and force. It's the same sort of idea about the nervous system. And then this other term you see here, bioplasticity, really has to do with, it actually should be biopsychosocial plasticity, the idea that the human is very resilient and changeable. And because pain is happening to the human, then we've got some hope that we might be able to change this. We also want to get her to recognize that there are many ways to change pain. And with practice, we can get better and better and better, that pain care techniques, self-care techniques are skills, and that when we master them, we will get better at them. They'll work even better down the road with practice. But you can imagine that for Fran, if we were to start with that, when someone who really has this tie between tissue and pain, to then jump to, hey, you know, there's lots of things that you could do to change this, whether it's movement or whether it's knowledge, the person's going to have a hard time accepting that, because it doesn't make sense in terms of their initial beliefs. So we need to find a way to get Fran and a way to get other people to consider new ideas around pain and around recovery. So there is evidence around positive effects of education. So education here, I'm talking about educating people about pain through talking to them, through using visual, like slides. We often have slides or videos that we use when we're educating people about pain. And we'll often give them handouts or booklets or books to reinforce the information. So we do have some evidence around the positive effects of education for people who have persistent pain. And I thought I'd just put up a couple of the more recent articles here. I'm going to talk a little bit about these too. The first one is a systematic review. So they've looked at a lot of the other research studies, put them together to come up with some ideas around the effectiveness of educating people about pain. And then the second one's really interesting because it's a qualitative study, and they're looking at if you were to talk to people before they were educated and talk to them after they're educated, were you actually able to help the person understand pain in a new way? Could they reconceptualize it in a new way? And so what they actually found when they interviewed people before and after the education is that there were degrees of reconceptualization. So some people heard this new information and it actually changed their beliefs and their attitudes towards pain and recovery. But what's interesting is some people, there was no reconceptualization. The person didn't have a new way of understanding it. There were some people who were partial, and one of the really interesting partial bits were that for some people, they said, well, this has changed my understanding of pain, but I don't see it how it relates to me. So interesting that sometimes people will start with the understanding of, okay, see, I understand pain as this broad thing, and maybe I need to understand it differently, but that's not what's happening in me. So that's a sort of a partial reconceptualization. And there were some people who actually took the information in, and there was this almost complete reconceptualization. They also found that it worked way better when it was relevant to the person. So when we're providing this education, it needs to be relevant to the person's situation. As an example, they mentioned that there seemed to be a focus on low back pain, but one of the fellows in the group had neck pain and pain, I think, was swallowing. And so he couldn't see how this related to his specific issue. They also looked at the importance of prior beliefs. So the more strong the person's prior beliefs were about pain, the more likelihood that it was harder to change it. They made me, as they said this, I was recalling this idea that working with a person at one time who had a history of having a back pain, and nobody seemed to be able to figure out what was going on. Then he saw this particular manual therapist who assessed it and said, you know, I think it's this. I think it's totally different from what everyone's been saying. And I've got the treatment for it, and did that treatment to him, and he got better from that. And so now this person had this very strong belief about if pain persists, the problem is not the nervous system. The problem is that I need to find that special person who can figure out exactly what's wrong and fix it, rather than thinking that maybe there's something other than the tissue issue at play here. And so the last thing was the perceived benefit. Is some people, they perceive the benefit of this, of understanding pain more, but some people actually perceive the benefit of it around how could they change the way they cope, or how could they change the way they function. And hopefully you can understand that if a person's educated around this, and it starts to, they see it as, oh, this is going to help me live with more ease or move with more ease, that's probably going to give them a very different outcome from it. So in terms of the more research-based side of it, and if you look at the research, what they've shown is that when we teach people about pain through verbal education and books and things, is that it improves the person's sense of disability, so perceived disability, or the person's perception that they can be more able increases. And what they're able to find is that the research says that it improves it in the short term. And part of the reason that they've said that not long term is because there's not a lot of research that has looked at the long term effects. So we don't know that one way or the other. We also found that when that education is provided, that it improves functional outcomes. So the person's able to move with more ease, or if you measure their movement, there's more movement, and it's better than providing physiotherapy without this kind of education. So if you do all the other aspects of physiotherapy without the pain education, there's benefits. Add in the pain education, and there's better benefits. So they also found this, so you're seeing TSK on your screen right now, the improvements in TSK. So that's Tampa Scale of Kinesiophobia. So more clearly, what is a scale that looks at fear of movement in certain ways. And they found that for a lot of people getting this education, it actually decreased their fear of movement, which you can say, well, that would be a good thing. The person is seeing that movement is less threatening. And hopefully that will translate into that the person will actually be able to move more. But it is an interesting thing, is that sometimes people have this sort of shift in their cognition as they think, okay, I understand that this movement isn't so dangerous, but there are some times when people have that understanding, but the movement still is dangerous, which it's always hard to try to come up with a good explanation of that. But it would be a little bit like if I was sitting here in this room and way over by the wall, there's a spider over there, and I may know that I'm safe. So say that spiders create a stress response in me, and I may be sitting here knowing that that spider is a long way away from me and I am safe, yet my physiology may still be rising up. And it's an interesting sort of difference, is sometimes this knowledge decreases the threat value of movement, where the person says, yes, I know it's not so dangerous to do that, yet when the person does it, the physiology starts to get into that more wound up state. Anyway, so the research by itself, or so the education by itself through the research, says that it decreases fear of movement, and that fear of movement is predictive of how much disability you have over time. So that's good. The last bit is this, is that the education has shown really variable, the pain education, verbal pain education, has shown really variable results in terms of changing pain intensity. So some studies have shown that the change in pain intensity can be even up to 3.5 on a 10-point scale. But not all research has looked at this, and definitely when you look at these systematic reviews, overall they say that there's no consistent change in pain across people, either when you give them this education for low back pain or more so for more musculoskeletal issues. So if we sort of jump back to Fran, if we were to give her this verbal and written education, we may see that it decreases or increases her perception of how able she can be over short term. That it might be better if she had the physiotherapy she had. It might have been better if they had added this education in. We don't know, but it might have been. This kind of education would decrease her fear of movements if she's like most people in the studies, but it might not change her pain very much. Which really becomes interesting is that we often see people in physical rehab who will say, I can move so much better now. And I'm returning to my life activities so much more, and the pain is still there. So maybe the pain's changed a little bit, or maybe it hasn't really changed much at all, but I've been able to recover function almost despite the pain, which is webinar to in itself to discuss that sort of response. Anyway, so when we do explain pain, so we're going to get to the movement shortly, but in terms of if we're using movement as pain education, I want to talk about what we hope to get through providing people with pain education. So what we're hoping is that we'll get people to this idea that to reconceptualize pain, to perceive pain or have beliefs about pain and about recovery in a new way. And part of it is so that they'll reconceptualize pain as not being a danger meter or decreasing the threat, as we've talked about, that the research showed. We also hope that people will reconceptualize recovery as something over which they have some influence. So part of the message of explaining pain or teaching people about pain, whether you use movement or verbal, is to give that person the idea that both that it's changeable, but also that there's some capacity for the individual to influence their pain and function as well. So that's part of what we want to do through explaining pain. We also want to get to somewhere near the answer to how am I supposed to move more when movement hurts. It's a pretty shocking thing, and some of you have heard me speak before or heard me say this, is the idea that people in pain usually know that when pain persists, we know that more movement would be good. We know that being more active would be good for us in so many different ways. But one of the problems is that nobody really explains to us how we're supposed to do it without making the pain worse. And so when we explain pain, one of the outcomes that we hope is that the person will have some ideas or some options of how they might approach exercise or movement in a way that wouldn't flare them up or wouldn't cause them more tissue harm. One of the other things that we do when we explain pain is try to build a therapeutic alliance. So this is another really interesting one, because there are still, when people talk about pain education, sometimes they say if you don't have a good alliance with the patient you're working with, is that the education really won't work. I would ask you to shift it around and view it another way, is that if you are a clinician and you're providing pain education, part of the reason you're doing it is actually to build an alliance with the person. So if you can get the person as curious as you are about the complexities of pain, about the different options that we might be able to move forward with it, then you're actually going to be working from the same sort of place, and will be able to do goal setting better when you're working with the patient as well. So during any pain education, what we're trying to do is teach people a way that moves, that doesn't leave them worse, obviously. We want to teach people that pain is changeable, that it's not immutable, that actually pain is changeable. We want to teach people that they have some influence over their pain, and that even when the tissue is not normal, it's still possible to change pain and function, that's a hard one to get to. And maybe, as we sort of talk about the movement piece, you can recognize that might be one of the reasons why movement could help, if we can find the right way to do it. And we want to do, through this pain education, we want to get people to be curious about pain and recovery, because often when we're injured, we're thinking, like Fran is that there's only one path. There's only one thing you could possibly do that would give me less pain and better function, and that's to fix the tissue. But to try to get people to be curious about whether pain is more complex than that, and whether recovery is more complex than that. I mean, sometimes we use simple metaphors with person or previous experiences to say, have you ever met somebody who had a particular injury to the body, and the medical system said, you're never going to be able to do this activity because of that, and the person set out to prove them wrong. And sometimes the medical system is saying, I have no idea how you've regained that function. It's great that you do, but I have no idea how you did it. That's a very sort of linear view of our human resilience. And we're also trying to provide some realistic hope. I mean, it's important to give a person in pain, like Fran, to give her some hope, but it needs to be realistic, not just rose-colored glasses kind of hope. And we try to do that through this education. Now, as I'm saying all this, one of the things I'd like you to consider is there's probably been a time in your life when you wanted to learn something. There was something you wanted to learn. And you may have experienced that the person in front of you was doing a little bit like what I'm doing right now, is telling you all this background around it, and telling you how you should, to do this, you need to do all these things. And to do this, you need to understand why you should do it. I don't know if you've ever remembered that, of like trying to stop yourself from being rude and interrupting the person saying, would you just show me how to do it? And I think that's an important piece to think about here, is that there are some times in life when the best way to learn something, actually I should say, I believe that there are some times in life when the best way to learn something is by knowing why it would work and knowing how to do it before I try to do it. And there are other times when what I'd really like to do is just have someone show me how to do it, and then learn through the doing rather than learn through the sort of acquisition of new knowledge. So pain education is using an approach of acquisition of new knowledge, which is really, really important, but it's providing that knowledge through verbal things and written, and sometimes doing it through doing might be a better way to go. So before we get on to movement, this is another interesting thing, because a lot of times when we educate people about pain, we use story and metaphor. And so part of the thing is, if someone tells you a good story, what will happen is you'll start to, it's almost like you're there, you're in the midst of the story. And when the story is really good, you start to experience sort of what's happening to the characters within the story. And so we can use story sometimes when we're educating patients, because it allows the person to have an experience that's inconsistent with their previous beliefs about pain. So let me explain this, I guess, in one way. Say a person has low back pain, and someone unfortunately has told them, or showed them their x-ray and said, look at these changes on your x-ray of your low back. We call this degenerative disc disease. You've got that. That's why you have pain. And so now the person has this story of unfortunately tissue damage and pain. There's no way you're going to be able to have no pain or improve your function if this problem is there in your back. And so what we might do with that person is, the person says that to me, say as a physical therapist, and I could say, well, that's sort of not really true. Is that, here's some statistics that show that there are, 60% of the world who are your age walking around the world with no pain. So if we took everybody in the world your age and we did x-rays of their back, 60% of them have the very same problem you've got in your back, but they have no pain and no functional limitation. And so what's happened here is that the person has a belief, they have an understanding. And then what I've done is I've told them, well, you're wrong. And of course, we recognize that often what happens when we do that is a person will move away from us. When someone tells you that a belief that you have is wrong, you're likely to resist that. But through story, sometimes what we can do is we can give people a story that's inconsistent with a belief, but during the story, because of the experiential part of it, it's like a softer way of considering. Right? So if at the end of the story, you're saying, oh, okay, that makes sense that pain and tissue damage don't always match up. And I'll tell you about a story like that in a moment. But if at the end of that story you have that, oh, okay, yeah, that makes sense, but that's really not what you're thinking about your pain, it provides you with an opportunity for you to start to wonder about, oh, maybe I don't have a complete understanding of what's happening here. So I'll borrow a story from Lorimer Moseley, just because this one's an abridged bit of one of his stories. He says he's in Australia. He goes to the beach one day with his wife, and they're both really tired. They lay down. He falls asleep really quickly, and sometime later he wakes up and he sees his wife sort of banging her head like this and almost shrieking. And he, trying to wake up, and he doesn't really understand why she's making such a big fuss about getting water in her ear. But it turns out there wasn't water in her ear. What happened was, like him, she fell asleep on her towel, and she woke up because she could feel something had crawled into her ear, and she moved her head around, thought she had got it out, but then she felt it move again, and this has been happening for a while, and now she's pretty much ready to rip her face off to try to get in there and get that bug out of there. So they try what they can, and it's not working, so they take her to the hospital. When they get to the hospital, all emergency departments. If you had something like this, it's not a priority, and so they have to wait. And so they're waiting for about 2 hours, and you know, he's trying to get her to calm down, and she's telling him to bugger off, and you know, they're just having this sort of tension happening between them. And about a couple hours along the road, this fellow comes along and says, you know, can I help you? And they're like, well, yeah, she's got a bug in her ear. And he says, well, come on, I know exactly what to do. We'll take care of you. So he takes them back behind this curtain, pulls the curtain around, and asks her to just lay down on the bed there with the bug ear up. And then a few minutes later, he comes back and he's got a bottle of cooking oil in his hand. He just pours it into her ear and asks her to just wiggle her head a bit, and then pours some more and asks her to wiggle her head a little bit more. And then after he does that a bit, he says, just, you know, I'll be back in a couple of minutes. Just, you know, just stay there, but just move your head around a little bit so you can see if we can, you know, get that oil to go all the way in. And so a few minutes later, he comes back and he asks her to roll over on her other side. She rolls over onto her other side. The oil starts to come out of her ear, and the now drowned dead black ant that was in there comes out. And so everyone's sort of calming down. And Lorimer says that he looks at the fellow in front of him, and he says to himself, doesn't really look like a doctor. And he starts to scan down the fellow and thinks, yeah, that looks like a you know, construction shirt and construction pants. And yes, there are construction boots on this fellow. But what he notices is there's a blood-soaked rag around one of the guy's boots, and it looks like there's a 2x4 at the bottom of the guy's boot, sort of cut off on either side of the boot. And so he says something to the guy like, I guess you're not a doctor. And the guy says, well, no, you know, I've been sitting down the hall for the last 2 hours like you, waiting for someone to come take care of me. And I knew what to do to help. And I finally decided I'd come and offer you the help. And then Lorimer's wife says, but you know, what happened to you? And he said, oh, it's stupid. I was at work this morning and I jumped down. I shouldn't have. And I jumped down and a nail's gone right through the bottom of my boot, and it's, you know, in my foot. And yeah, so it's sort of embarrassing. And she says, doesn't that hurt? And he says, well, you know, it's not really a big deal. I had it happen before. They just need to cut the boot off and, you know, give me a tetanus shot, stitch me up, and I'll be as good as new in no time, just like last time. So here we have this, if we come back to the sort of the moral of this story, what's happening here is you've got a guy with a nail in his foot, and the nerves in his foot would be sending a lot of danger signals up towards the spinal cord, and maybe they're heading up towards the brain, but he's not feeling any pain. And the story here would be, is he's not feeling any pain because it's not really that dangerous to him. He's actually sort of more embarrassed and upset that he's not able to work than anything else. And so also that he knows he would be okay, so it doesn't hurt a lot. Whereas Lorimer's wife has a bug in her ear. It's, you know, it's moved around in there, and it's given her a lot of pain. And so why is there a lot of pain there? Well, there's a lot of pain because if there's a bug in your ear, you're thinking about earwig stories, or you're thinking about Star Trek, the movie. So, you know, your mind is going with the, you know, there's a sense of it's going to head on further in. And so there's this high level of potential danger to this. And so to him, it's not that dangerous. To her, it feels really dangerous, and that how dangerous something feels to us has a big influence on our pain. Anyway, all that story, that kind of story, is to give a person an experience through the story that's inconsistent with the person's previous belief about what's happening in their body. And I'm hoping that you're sort of jumping right ahead to this idea of, oh, okay, so if you could give a person an experience through a story, could you give a person an experience through movement? So when we teach using story, it's just the person's experience. The listener has an experience rather than just learning facts. And we believe that that makes it easier to learn new things that are contrary with our previous beliefs or our previous determination of how dangerous it is. And this last bullet down at the bottom here was just that same idea of when a person says something like, I can't lift that because I have a diagnosis of degenerative disc disease, it sometimes doesn't work all that well to just say, to give the person information that's we believe is true, that that's not a diagnosis. And the research says that many people have that and they have no pain. And so you should be able to do it. So you can see that the one is the experience is probably a way that most people learn with more ease. So finally, we get to the movement piece. So is it possible, if we can teach people through education, could we teach them through movements? Might some people learn better through doing? I'm sure that you recognize that there are a lot of people who haven't learned to learn through someone talking to them. Those of us who are healthcare professionals, we spend a lot of our life sitting in front of people talking like I am now and learning that way. But there's lots of other people who haven't learned how to learn in this particular way. They've learned how to do. And so this other point here, the third bullet I think is important, is that it's a fascinating bit of to a lot of us, when we change the way we think about something, that's real. But what's really real is when we can change something about our physical function, right? So you can teach me a new thing about me or about humans, but if I experienced it in my physical self, somehow it feels more real than a thought. So when you change when I know that when you change the way I think, or the way if you could help me change the way I emote, that this is real. But even with all that knowledge, it still feels a lot like if you can change something I do with my physical self, that's more real. And I'm sure that's the same way it is for some of our patients. Hence the idea of, could we use movement as an educational agent? So we need to start with this idea that movement typically hurts, so we're going to have to do something about this, right? In part, the movement hurts because the nervous system is sensitized, so what are we going to do about that? Well, one of the things that we tend not to think of when we're using movements as therapy or using movement as education is that we could get the person to move in a way that doesn't leave them worse. And because we know that movement itself can actually change the chemistry of the body, that can actually decrease pain. Sometimes a way to start would be to get a person to see how much they can move where the pain doesn't get worse, and just start to move in there. And the experience of that, of moving without being worse over time, first of all, the person starts to feel more self-efficacy. But if that could change the chemistry of the body, then that could also change the pain and then feed back into ease of movement. Or what if it hurt so much to, like, even small movements hurt a lot? The person said, it's not a lot of movement I could do. Well, we're talking about the nervous system here. And so what about if we started with imagined movements before small movements? Olympic athletes do it when they're trying to gain the ability to move more. And so if I sat here and I told you, hey, Olympic athletes use imagery, and this is all the reasons that imagery could work to make it so it'd be easier for you to bend forward, or if you're a Fran, easier for you to lift your arm back up again, that may be very different than if I just said, okay, I'm going to guide you through an imagery technique. And so I take you through an imagined movement technique, imagining movement of your body, a movement of your shoulder, and in the image, you're moving it without pain. At the end of doing that, if I got you to do the movement again and you had more ease of movement or less pain, now you've had an experience that's inconsistent with your previous determination of danger. And of course, hopefully you understand that if that was repeated over and over and over again, it actually can start to make it so that there's a retained or durable change in range of motion. And then what about if we instruct people in some pain self-care techniques? Because we know that there are things that people can do that would actually change the chemistry of the body, change the nervous system, endocrine system, immune systems, that would help to turn down pain. And if we got the person to do that while they were moving, could they move with more ease? And so we've got different ways to do this. Different ways that we could use movement. And so rather than starting with sitting a person down and talking to them about pain, one of the other options that I'm suggesting, and we do not have research around this yet, through the Gentle Movement series that Jen mentioned at the beginning, we've tried this out in communities and seen that it works somewhat. That rather than spending time on knowledge acquisition through talking and reading, doing knowledge acquisition through actually trying different approaches to movement, and that this can give people improvements in their ease of movement. But what it also does is it helps them reconceptualize pain. Hopefully you can understand that if you moved a bunch of times in a row and every time you did it, you actually felt better when you were done, or that your ease of movement was getting better, you're going to change your view that pain's from pain is immutable to, hey, pain is changeable. Your idea that there's no way to move more with that tissue injury if you experience it, well, it's sort of hard to continue to have that belief that would limit you. So with this idea, I'm sure you've all had grandmoms who said, mind your, maybe it was mind your manners, mind your language. This sort of idea of mindful movement. So what is mindful movement? Well, I think when my grandmom was saying this to me, what she was saying is pay more attention. And mindful movement is we're doing the movement and we're paying attention to what's happening. We're not distracting ourselves. We're not watching a movie while we're at the gym doing exercise. Being mindful around movement means being discerning, starting to differentiate, to actually pay attention is like, does this movement feel safe? Does this movement feel like it's dangerous? Does this movement feel like I will be worse later? Spending more time and actually discerning the response, or maybe noticing when I do this movement, I can't do it without holding my breath. So maybe that's not the right movement to do just today. Maybe there's another approach you need to take before you come back there. Being mindful means not being reckless. Reckless is the idea of just gritting your teeth and using your strength of will to persevere in the face of this. So that's sort of what mindful movement would be about. And it's also about this idea of think about the thoughts and emotions you have right now, and you don't need to be controlled by them. So, when my grandmother was saying, she's saying like, pay attention, right? You want to do that right now, but that might not be the right thing to do in this kind of situation. And so we know that when there's pain there, we often, the fear of more injury, the fear of more pain, the thoughts that we actually can't control things can be problematic. And so this stuff can come up. These things can come up when we're trying to move. If we could teach people to move and notice those things and start to regulate them and take a different approach, there might be both a different response to movement, but the person would start to learn these ideas. Pain can be changed. I do have some influence over it. There is some hope of regaining function, regardless of what the tissue issue is in my body. And so for those of you who have heard me speak before, I'm sure you recognize this idea that awareness practices can be really powerful. Research is even showing that awareness practices are pain relieving, and that's helpful. And awareness practices can have to do with breath awareness, body tension, body sensation awareness practices. We also know that self-regulation practices. So awareness is when you're paying attention to what's happening. Self-regulation would be when you're saying, I noticed that and I'm going to change it. And so we know that sometimes when you move, you hold your breath. And if you start to change that, it can change the amount of pain with movement. But also you might notice that your body gets really tense, or you get sensations in your body, and that you might be able to regulate those. And that would make movement better as well. We don't have time to really get into those here, but there are other places on the Pain BC website where there's lots of instruction in both awareness and self-regulation techniques. And for those of you who are here, you've probably heard these ideas of the movement guidelines before. If we get people to move, and while they're moving, asking themselves, am I safe? Will I be okay later? Can I calm my breath? Can I calm my body tension? Can I pay some attention to the pain? That this is a different approach to movement. And when we get people to start to move and we start to tell them these guidelines and get them to rehearse this while they're moving, they often find that they can move with more ease. And once again, when the person moves with more ease repeatedly, then this is an educational agent, an educational moment in which the person will start to understand there is a possibility of change. It is realistic to have some hope that I can influence this myself. All those things that we want to change with pain education, verbal pain education. So why might movement work? Well, maybe the person has never learned how to learn through verbal and written instructions. They've learned through doing, so maybe movement would work better for this person. Or maybe it's just another option. So I'm actually sort of juxtaposing these a little bit as try this or this, but maybe we need to consider that we could use them both together to get possibly even a better effect. And so maybe these physical changes are more convincing to the person. And this third point here I think is important, is that the research suggests that some people, when we teach them about pain, is that they reconceptualize pain, but don't apply it to their own situation. But with movements, if you acquire that same knowledge you're actually acquiring it about yourself. So it makes it personal right off the bat, and that might be advantageous to do that. It can improve self-efficacy, the person's confidence that they can control things. Maybe it works because the changes with movement can be repeated. So a person can do a movement over and over and over again, and that repetition could be what helps change things down the road. So just want to quickly mention to you, if we went away from FRAN'S experience to an osteoarthritis experience really quickly, is the idea is that we know if we look there that through the research that says that exercise for people with OA doesn't just work because it changes the tissue, it works because it changes the central nervous system and these descending inhibitory effects from the brain. It works because it does change the body, changes strength of muscles, and it can change the tissue in the body when we can apply the force right. It works because it changes these pro-inflammatory chemistry of the body that we talk about now. It can change the exercise that we get people to do, can also change what's happening with our cognitions and our emotions. We also believe that it can change people by changing body awareness, proprioception, body image, all those things as well. By changing hormones, the chemistry of stress. So the movement, the research around osteoarthritis is saying this as well, which I think is important because if movement over there is affecting the person on so many different ways, then those changes the person experiences, once again, could be used as an educational opportunity to get a person to understand that OA does not just have to do with what's happening in the joint. It has to do with what's happening in many aspects of the person. So we talked about non-pharmacological care at the beginning, and just sort of wrap this up, there's this idea that non-pharmacological care that the evidence says that works is that pain education, if we can get a person to reconceptualize it, that can be helpful. Providing it with movement seems to be more helpful. We know that, or we believe that when you're trying to get a person to move more, that it would make some sense to give people other techniques that would decrease the pain, take the pain from up here down to here to allow the person to move with more ease. There's some evidence that says that mindfulness, even brief mindfulness practices or awareness practices work. There's some evidence that says that breath regulation helps us with pain in other ways. But hopefully you understand that these could be used as educational as well. That if a person does this and it changes their pain, that hits back at one of the main things that we're trying to teach people is that pain is changeable. So we also know that goal setting is really, really powerful. We haven't talked about that. That's another piece, but I just wanted to remind people, the clinicians, that the science around goal setting is pretty good as an intervention as well. So we get back to Fran. Could we provide her with a movement experience that doesn't worsen her pain, and would that help her to understand pain in a new way? Could we get her to do exercise in a new way, or movement in a new way, that when she did it, at the end of it, she actually could move with more ease, because that's going to teach her that pain is changeable. She has some influence over it. Could we do it in a way that would decrease her fear of movement, because that seems to be a piece of what was happening with her. So if she can do it with less pain when she does it, and that decreases the fear, that's going to decrease the threat value of pain, which is part of what we're trying to do with pain education as well. And so to say in a bit of a different way is, could we provide her with these movement experiences that are inconsistent with her belief that the only way to change this pain would be to fix the tissue. And hopefully you're getting the idea is we can do this through movement. We just have to approach the movement in a different way. So the green ones here are to come back to what could we use movement for? Well, we can use movement to help a person reconceptualize pain as having to do with more than just the tissue. Because if we can get people to move with more ease, because that can be hypoalgesic or analgesic for some people, you could use movement actually as the pain relief. We can get people to do mindfulness and breath regulation and body awareness things. There's some evidence that each of these can decrease pain as well. And we'd want to integrate these with the movement to make it more successful. So to finally wrap up, what we're talking about is acquiring knowledge. So we can acquire knowledge this way, or we can acquire knowledge this way through guided movement, doing it in particular ways. We can also educate people through getting them to do things like distraction techniques, or techniques that will give them a little bit of respite from the pain. We can use calming techniques to help people to learn that pain is changeable as well. But I think in the end, what we really want to do is find a way, if we're going to use movement as an educational tool, we want to get people to do it with other people. That seems to be where the best benefits are, and integrate the other techniques like awareness and regulation that will also help, and hopefully do it in a way that's, once the person has that experience of being able to move with more ease, that there would be a practitioner there who would say things like, that's fantastic, your pain changed. Imagine if we keep on doing this over and over and over again, about how much better you'll be able to change this. And hopefully you can see in that moment, there's an opportunity to provide the person, or the person's gaining so much new understanding about pain that they may not have had before. And it's reinforced by their, the movement practice or the experience that they just had, rather than just believing it because I said it. So that's a quick run through that. I think we have some time for questions, Jen.
Wonderful. Thank you so much, Neil. That was fascinating as usual. So there's been a couple questions, and please type in your questions in the Q&A, or you can even raise your hand and ask Neil the question live. If you do that, just give me a minute and I'll unmute you. So just first two. So one person was just wondering if this webinar is going to be recorded and available and sent out. Yes, it will be. Another person has asked, they say they're an RMT and struggling with educating clients and feeling like they're often contradicting their physiotherapist and sort of the hierarchy of healthcare providers. And she is asking, do we have any client and or patient resources that explain pain science concepts? So I have actually answered that, but Neil, you can add to it. One is the Gentle Movement course, has, again, free for everybody in BC, and Neil has created these amazing resources for us that you can use with patients. So you can download those resources and even use them outside of the movement class context. Mm-hmm. Neil, do you want to add anything?
Well, I think the other thing that's on the Pain BC website, the webinars we did a few years ago called Empowering Self-Management of Pain. So within that, there's it provides a pain education, and then moves into, if that's the way that this whole pain thing works, what could you do in terms of self-care? And so that's there, Empowering Self-Management of Pain. It's Jen, I'm not sure if it's within Live Plan B, but it's definitely on the Pain BC's website.
So yeah, I have it. I've searched it on liveplanb.ca, and I'll just send that out in the chat, so you can look there. Okay, great idea. Okay, so we do have another question. Neil, do you have any advice for clinicians addressing RTW and how to encourage movement and exercise?
Wow. Yeah, when you get, so RTW, return to work. So this becomes such more complex issue. We're trying to get a person to move forward with this goal of return to work, and sometimes sometimes we need to teach people who are trying to get back to work, or the system is saying it's, you need to get back to work by the state. Sometimes we need to teach them pain education so that they can approach movements in a new way. And sometimes what we even need to do is teach them it so they can understand that the best thing to do right now is just back up just a bit. Because a lot of times people, what they're doing is trying to use their strength of will to push through it. And in some people, that pushing through it can actually leave them worse. It can almost like it makes the nervous system more sensitive or more sensitized. And sometimes understanding the pain better, it lets the person understand, okay, backing up temporarily will help me move forward better. There's lots of other issues around this, and that would, it's a return to work is such a big thing. But I would say is use the education, recognize that it may say to the person, I need to do less to start, but encourage the person with the ideas that sometimes you need to just step back a little bit, calm things down, and then you'll move forward way better than trying to just be tough.
Thanks, Neil. Okay, I've just shared the Empowering Self-Management webinars in the chat, so you can grab those links from there. And again, it's just in liveplanb.ca. Okay, a couple more questions here. Do you have any thoughts, education, and resources to share on the use of braces, for example, back braces, and their use with pain versus muscle atrophy?
Wow. You know, I haven't looked at that topic for a long time, but mostly what we're trying to do with people who have, you know, with most back issues is to decrease the threat value of movement and get a person to move with more ease and actually start to avoid less things. And so there's you know, braces, I could see how they could be advantageous to give things a chance to calm down. But there's that other piece of muscles atrophy, but it's not just muscle atrophy. It's it changes confidence. It changes one's sense of stability. And so as I say this, I realize what I'm actually saying to you is really my beliefs about this. And like I said at the beginning, I really haven't looked at the research around this for a long time. But I would, from everything I know, I would tend to, if a person was in a back brace, see if there's a way that we could get the person to start to spend some time out of it, more time out of it, more time out of it, right? Recognizing that, you know, taking a person out of it could crank up the systems, and we'd need to find a way to progressively do that. But that seems like the right approach.
Thanks, Neil. Okay, another question. How much time would you say is needed to change the pain concept for GRTW clients without pushing or making the client feel unsafe or not comfortable with movement?
Right. Well, first of all, I would say, so GRTW, graduated return to work clients. So I think the first thing I would do is remind everyone that pain is individual, and how long it's going to take is going to depend on so many different factors. You know, how strong a person's beliefs will mean that it will be harder to change this, because expectation really drives outcome. We know that, interestingly enough, you know, if they look at brain changes, is that the thought would be, if, well, the brain changes are bigger, maybe that would take longer to change them, but we actually don't see that. So I would say the only predictor of how long it's going to take is give it a try. Right, so get a person doing something that would potentially change nervous system sensitization, get a person to do things that would change their, that would help them reconceptualize the pain. And if you get that, you're going to have to repeat it a bunch of times. But I don't know how many times you're going to have to repeat it. You know, for any patient I work with, I couldn't tell you how many times I'd need to give them a new experience until I try. We know that, you know, severity of pain predicted is going to be harder to move forward. We know that anxiety suggests it would be harder to move forward, harder to learn new things. There's some evidence that previous, how solid a person's beliefs in the past would make it more resistant to change. But we don't know for certain. So I think the best thing to do is provide a person with an experience that's inconsistent with the previous determination of threat, and then repeat it a number of times, like you do with any other clinical intervention. And that'll start to give you an idea of the trajectory of change here, whether the trajectory will be really quick or whether it's going to take more time. So I don't have any evidence to make it more precise than that.
Neil, thanks so much. I'm not seeing any other questions at the moment, so, and it is 1:02. So we are at time. Just want to thank you again for the presentation today. It was excellent, and it will be emailed out to everyone who registered. Oh, sorry, just one more question maybe. Oh, no, oh, hang on. Oh, no, just lots of people saying thank you. So that's always nice to hear. Well, thanks everyone for attending. Really appreciate your time today, and do join us next month for our next webinar. And hopefully we'll see you soon.
Thanks.
Thanks. Bye.